Hello, welcome to my channel. Don't forget to like, comment, and subscribe, as well as passing comments on the future content that you'd actually want me to cover. The video in focus today will actually be looking at the neuroanatomy of the auditory pathways, starting, of course, from the pinna all the way to the cerebral hemispheres. You're going to be having the pinna picking up the sound. Then the sound will then be conveyed to the tympanic membrane, which is going to actually be vibrating. And those vibrations are then going to be passed on to the ossicles of the middle ear, that is the malleus, the incus, and the stapes. Then from the footplate of the stapes, the vibrations will be passed on to the fluids of the internal ear, where now you're going to be having the organ of Corti that is going to be having the hair cells, the inner and the outer hair cells, and vibrations of the basilar membrane. Of course, high frequency sounds will cause vibrations at the base of the basilar membrane, whilst low frequency sounds will actually cause vibrations at the apex. And those that are not within the audible range, they're just going to have the fluid vibrations move from the scala vestibuli to the scala tympani via the helicotrema, right? So you're going to find that these vibrations of the basilar membrane, they're actually going to cause conformational changes in the tip links that are within the hair cells. And remember, the stereocilia, they're actually going to be beating towards the kinocilium for you to be able to perceive sound. And that is then going to result in opening of mechanically gated potassium channels that are then going to allow for potassium influx into the cells. This potassium influx is going to cause a depolarization within the hair cell, the inner hair cells in particular. And this depolarization is actually then going to result in further opening of voltage gated calcium channels that are then going to cause more depolarization, and the end result will actually be release of an excitatory neurotransmitter that is going to be glutamate, right? So each inner hair cell will contact about 10 neurites, but no neurite or single neurite will actually be contacted by more than one inner hair cell. They find that most of the afferent fibers, or 95% of the afferent fibers that are going back towards the central nervous system, they'll actually be conveying information that is coming from the inner hair cells, right? So the outer hair cells are mainly for modulatory, and they're going to receive most of the olivocochlear bundle nerve fibers that are acetylcholine in nature. And that acetylcholine will actually result in hyperpolarization, and then you have relaxation of a protein molecule known as prestin, and that is then going to result in less shearing, because it's going to move the basilar membrane down. So it's going to result in less shearing within the inner hair cells with the tectorial membrane. Then you have less perception of sound, but we'll describe that when we get to the descending pathways of the auditory pathway. So you're going to have what is known as the spiral ganglion. The spiral ganglion is going to be characterized by having bipolar neurons that are then going to be having a peripheral process that is going to be, of course, contacting the inner hair cells. Then the central process is going back towards the central nervous system, particularly to the dorsal and the ventral cochlear nuclei, right? So you're going to have a canal within the temporal bone that is going to be your internal acoustic meatus. Within the internal acoustic meatus, you're going to be having the vestibulocochlear nerve that is going to be having both the vestibular component and the cochlear component. On top of that, you're also going to be having the facial nerve, as well as your labyrinthine artery that is coming, of course, from your basilar artery, and it's going to the internal ear. So those fibers, they're actually going to traverse the cerebellopontine angle, or the subarachnoid space of the cerebellopontine angle, before they actually enter the pontomedullary sulcus. And from there, they'll then synapse at your dorsal cochlear nucleus, which is this one, and the ventral cochlear nucleus, which is this one, right? Still within the internal acoustic meatus, you can have development of what is known as a vestibular schwannoma. That is mainly due to a mutation in neurofibromatosis type 2 that is responsible, of course, for the production of a protein known as myelin. So that will result in less actin filaments, and that's going to result in division of cells that are actually not anchored to the rest of the cells. That's going to result in a tumor that is a vestibular schwannoma, and that is going to result in ipsilateral deafness if it actually affects the the cochlear component. And if it then extends all the way to the cerebellopontine angle, you can actually affect the nearby nerves to include the glossopharyngeal or the vagus and so forth. So that will then result in lots of things like the gag reflex. But remember, the gag reflex is actually going to be having an afferent limb that is glossopharyngeal in nature, and an efferent limb that is actually going to be the vagus nerve. So you can actually lose the gag reflex. Then, so for this video, we'll particularly focus now on the cochlear nuclei going all the way up to the cerebral hemispheres. So any lesion that is going to occur rostral to these cochlear nuclei will not result in ipsilateral deafness, because most of the things are going to be bilateral from this point, right? So the cochlear nerve fibers that are coming, they'll actually synapse at some of them will synapse at the dorsal cochlear nucleus. Then the other ones will then synapse at the ventral cochlear nucleus. The ventral cochlear nucleus will actually be divided into a dorsal part and an anterior part, right? We'll talk about that. The dorsal cochlear nucleus will actually be characterized by having the principal cells and the stellate cells, whilst the dorsal ventral cochlear nucleus is going to be characterized by having what are known as octopus cells. Then the ventral or the anterior portion is going to be having stellate cells, just like the dorsal cochlear nucleus. But on top of having those stellate cells, it's also going to be having what are known as bushy cells, right? So fibers that are going to get to the dorsal cochlear nucleus, notice they're going to cross the midline and go to the contralateral nucleus of the lateral lemniscus. So most of the fibers that synapse in the nucleus of the lateral lemniscus, they're actually fibers that are coming from the dorsal cochlear nucleus, and they make up this stria, which is the dorsal acoustic stria, right? Then from your ventral cochlear nucleus, from the portion that actually has the octopus cells, or from the dorsal portion, you're going to have what is known as the intermediate acoustic stria. This is the intermediate acoustic stria. And notice it's also crossing to go to the contralateral side, right? And fibers that are coming from the ventral cochlear nucleus, some of them remain ipsilateral and some of them actually become contralateral. And those that are going to be coming from the most anterior portion, which are these ones, they make up what is known as the ventral acoustic stria, alternatively referred to as the trapezoid body. And these fibers, they either synapse at the ipsilateral superior olivary nucleus, or they actually go to the contralateral superior olivary nucleus. The superior olivary nucleus, if you can notice from this illustration, it actually has a medial component and a lateral component. Those two components will actually be looking at two different components of sound. The lateral component is for the intensity, whilst the medial component is actually for the timing. Remember, we actually have that that capability of differentiating sound that is coming from the left and from the right side. That is what the medial compartment of the superior olivary nucleus will be looking at, right? But from this point, the fibers that then come from the superior olivary nuclei of both sides, they can either synapse at the nuclei of the lateral lemniscus, or they can actually bypass that nucleus and form part of this lateral lemniscus, right? Which is just a flattened band of tract fibers that are now moving all the way up to the inferior colliculi in the region of the midbrain, which is this portion here. Right. So you have the dorsal cochlear nucleus, you have the ventral cochlear nucleus, and notice those two nuclei, they're actually separated by the inferior cerebellar peduncle, right, which is joining the medulla to the cerebellum, right? Then from the nucleus of the lateral lemniscus, where you're having most fibers of the dorsal cochlear nucleus docking, those fibers will also join this lateral lemniscus, and they'll traverse the pons, then the lower portions of the midbrain, and they're going to synapse at the level of the inferior colliculus, which is this point here, right? Notice there's going to be communication between the two inferior colliculi, as well as the two nuclei of the lateral lemnisci. This is the same reason why I earlier on say that any lesion in the auditory pathway rostral to these cochlear nuclei will actually not result in unilateral deafness, right, or ipsilateral deafness, if you may call it, right. Then from the inferior collicula, you're then going to have what is known as the brachium of the inferior colliculus. From the brachium of the inferior colliculus, you're then going to have fibers moving from the inferior colliculus now to the auditory areas that are actually within the superior temporal gyri, the Heshu nodule, so the transverse gyri. Then you can also have the fibers also moving to the auditory association areas to include Brodmann area number 22, which is Wernicke's area. Remember, Wernicke's area being the receptive language area, it's going to be communicating with the expressive language area, which is Brodmann area number 44, 45, which is in the inferior frontal lobe. That is actually going to be known as Broca's area. And they're the two actually going to be communicating through the superior longitudinal fasciculus, which you can alternatively refer to as the acute fasciculus, right? Remember, you're going to be having three types of fibers that are going to be found within the cerebral hemisphere. Communal fibers being the ones that actually join the two cerebral hemispheres. Then association fibers, they join two different regions in the same hemisphere. Then you then have projection fibers that actually join regions within the cerebral hemisphere to subcortical structures, right? So this is how the fibers actually come from the internal ear all the way now to the primary auditory area, which would be our Brodmann area 41, 42, within the superior temporal gyrus. Right. Then you're going to be having what are known as descending pathways. And most of these descending pathways, they're actually going to be ipsilateral, except for the corticocollicular fibers that are actually going to be both ipsilateral and contralateral, right? So notice you're going to be having fibers that are coming from the primary auditory area. Some of them, they actually come from the inferior colliculi, some of them, they come from the superior olivary nuclei and so forth. These are going to be the descending pathways that are going to make up the olivocochlear bundle that we then say was actually going to release acetylcholine at the level of the outer hair cells, and that is going to result in a hyperpolarization within the outer hair cells, and that is going to result in the prestin molecule actually relaxing, and relaxation of the prestin molecule is actually going to cause the outer hair cells to elongate, and they're going to push the basilar membrane, and that is then going to result in less shearing of the tectorial membrane in the inner hair cells, because you're actually increasing the distance now between the tectorial membranes and the inner hair cells, and that is going to reduce the sound. So that's more or less a modulatory pathway. And also, if you're going to have, remember what is known as the reticular formation. The reticular formation, when sound is actually high, it's actually going to communicate or send communication fibers to the trigeminal nucleus and the facial nucleus, because within the middle ear, you're going to have the tensor tympani muscle that is actually a derivative of the first pharyngeal arc, as well as the stapedius muscle, which is a derivative of the second pharyngeal arc, being supplied by the nerve of the second arc, which is your facial nerve. So you're going to find that these high frequency sounds, or these high or loud, high pitch sounds, or loud sounds, they're actually going to cause activation of those nuclei that is going to cause contractions of these two muscles. The tensor tympani, its contraction will actually tense the tympanic membrane, because remember the tensor tympani will actually be attached to the malleus, and if you're going to tense the tympanic membrane, that is then going to result in less vibrations, and also the stapedius muscle, it's going to have an effect on your steps, because remember we said the footprint of the steps will actually be pressing on the oval window, right? Then you can have what is known as fibrosis of the annular ligament that is actually connecting the footplate of the steps to the oval window, and that can be a congenital malformation that can actually result in deafness. Then looking at the clinical correlates, there are two very important tests known as Weber's test and Rene's test. So in Weber's test, you take a vibrating fork, tuning fork of about 5 to 12 hertz, and you put it at the vertex of the skull. Then a Rene's test, we actually take the tuning fork and you bring it closer to the ear, then to the mastoid process, right? So in a Weber's test, right, you're going to place the tuning fork towards the vertex of the skull, and you're going to ask the patient where they actually hear the sound, right? So if these people have conductive deafness, right? So you have what is known as perceptive deafness or sensory neural deafness and conductive deafness. So this test will actually help differentiate or give a differential diagnosis of conductive deafness and sensory neural deafness. So if you place the tuning fork at the vertex of the skull, that is somewhere here, right? For someone with conductive deafness, the sound is referred to the deafer ear, right? That is, if I have a problem in conduction in my left ear, the sound will be referred to this ear, right? But if it's a sensory neural deafness, the sound will actually be referred to the normal ear. That is in a Weber's test. Then in a Rainer's test, you're going to take the tuning fork that is vibrating and you bring it closer to the ear, right? Until they tell you that they can no longer hear the vibrations. But if you then place it towards the mastoid process, right? If that patient can actually hear the sound again, that is at the mastoid process, right? That is now through bone conduction, right? That means you actually have conduction deafness within that ear. But if you don't hear the sound now, that means it's a problem within the sensory neural areas coming from the organ of Kochi all the way back to the cerebral hemispheres now. So that's a way of differentiating conductive deafness and your sensory neural deafness. Then you have what is known as tinnitus. That is actually perception of a sound that is actually originating in the head, not from regions that are actually outside. So you're going to be having a buzzing sound that is actually going to be within the brain. And that can also be as a result of focal seizures that are actually auditory seizures, right? So that's as far as I had for you in relation to the neuroanatomy of the auditory pathways.